people right now. So hi everyone, thank you for joining the University of Washington Division of Rheumatology Grand Rounds. Just a couple of reminders before we start. This session is currently being recorded and will be posted later on our website. There will be a Q&A session at the end, so please add your questions in the Q&A feature in the box below and not in the chat box so that it's easier to moderate. And now I'll let Dr. Mustelin introduce our speaker for today.
Okay, thanks, Danielle. So it is a real pleasure and honor to introduce Dr. Peter Grayson for today's Grand Rounds. So Dr. Grayson obtained his MD from the Medical University of South Carolina in 2004, and then relocated to Boston to do his internal medicine residency, followed at the Boston University Medical Center also a fellowship in rheumatology. And he must have liked it there a lot because he stayed around a little bit longer. He got a master's degree in epidemiology from Boston University. He did a scholarship in bioinformatics, and finally at the NIH, a scholarship in translational medicine. So he joined the NIH and NIAMS more specifically after being assistant professor in Boston. First to be an associate program director for the Rheumatology Fellowship Program, becoming an assistant clinical investigator at NIAMS in 2015. He then became the acting program director for the fellowship program in 2021 and held that position until January of last year. And from 2018, he's been a tenure track investigator at NIAMS. Dr. Grayson has an impressive list of honors and awards, and I think the one that stands out to me most of all is the NIH Director Award for the discovery of the VEXAS syndrome just about 3 years ago. He has a very impressive list of publications with around 130 papers and chapters in very eminent rheumatological journals, most of them. And again, I think what stands out to me is several papers in New England Journal of Medicine, including those that reported this new syndrome, now known as the VEXAS syndrome. So he is going to talk to us today about vasculitis, which is what most of his research has revolved around with multiple eminent observations and advances in the field. And he is promising us an interesting and somewhat unusual talk. So looking forward to that. Please go ahead, Dr. Grayson.
Thank you so much, Dr. Mustelin, for that introduction. Yes, it's hard to know in the virtual world. I know many of you are probably out there multitasking, catching up on some work as you sort of listen. I know I'm guilty of that many times with virtual Grand Rounds. I'll tell you that for this talk, it's going to be perhaps in areas that you're not very familiar, and so you may have to actively listen to follow it. But the promise is that I'm going to talk to you about what I think is going to be a key component of the future of rheumatology in terms of discovering what causes diseases and potentially curing them. And that really is this somatic mutation paradigm. And I'll use the discovery of the VEXAS syndrome as an example of this, but I also will diverge off of this and talk to you a lot of different ways conceptually about this topic. So somatic mutations are defined as post-zygotic mutations, so mutations that occur after conception. And these can occur anytime when you're a ball of cells developing in utero to throughout the entire human lifespan. So this is different than germline genetics, what you inherit from your parents and give to your children. These are acquired mutations that occur some point later in life. And there seems to be a real signal here that somatic mutations can play big causal roles in systemic vasculitis. So that's what I'm going to talk to you about, but this is not likely to be limited just to vasculitis. At the end, I'm going to show you a brand new disease that I haven't talked about anywhere. Maybe it's Vexus 2.0, so hopefully that will be exciting to you. This slide should scare you. It does me, at least. So this is work from the Sanger Institute, and what they did in this study is biopsied esophageal tissue from healthy people. And you can see there's 3 different patchwork plots, biopsies that were taken in people who were in their 20s versus their 50s versus their 70s. And you're seeing visually a square centimeter of healthy esophageal epithelium that's biopsied and then DNA sequenced, looking for somatic mutations, looking for clones. And if you look on the far left, you can see even in your mid-20s, in the prime of life, you've acquired mutations in your tissue. And the circles correspond to clones. The bigger the circle, the larger the clone size. And if the circle is colored in, it means that there's a mutation in a driver gene for epithelial metaplasia. So these are genes known to cause epithelial cancers. That would include things like p53 and Notch genes. So what you'll see as you get older, you start to see increased clonal abundance, clone size. And basically when we are in our 70s, we are polyclonal organisms. So even in just this one little square centimeter of tissue, it's just rife with mutations. And one can imagine that this same process is happening in every organ system throughout the body, including in our bone marrow, which is what the blood is comprised from. So most of this work in acquired mutations is actually focused on blood because it's a readily available tissue source. And if you're not aware of this concept of clonal hematopoiesis of indeterminate potential, or CHIP, then hopefully I'll make you aware of it by the end of this talk, because I think it's really important for rheumatologists to know what this is. But most of this literature has still been sort of clustered in the cardiology and hematology worlds. So what is CHIP? Well, it turns out that as we get older, in our bone marrow, we have mutations and clonal populations of cells defined by mutations in genes that are known to cause myelodysplastic syndromes and myeloid cancers. And if you look at the frequency plot on the right, this is basically saying that in healthy individuals, as they age, if you get above 70 years of age, 10% or greater of the population has clones in their bone marrow in genes known to cause cancers, leukemias. If you look at there's a list of about 40 or 50 of these genes, and most of the time, CHIP is defined by mutations in 2 genes, DNMT3A or TET2. And these are master epigenetic regulators. I want you to keep these genes in mind because we're going to return to them later as the talk gets a bit more complex. But you can imagine, it's called CHIP because these patients don't have cytopenia. They're otherwise healthy. But you can imagine that having these types of clones may increase your risk of developing a myeloid leukemia. And that is true, but it's only to the tune of about 1% increased risk per year. But where this literature got super fascinating is that from large epidemiologic studies, it's known that people who have CHIP are at increased risk of dying. And when you drill down on the mechanism of death, it's cardiovascular disease, so myocardial infarctions and strokes. And here I'm showing you hazard ratios from this work presented in the New England Journal, basically showing about a 2-fold increased risk. So if you have CHIP, you have a 2-fold increased risk for atherosclerosis and for death from cardiovascular disease. That's totally independent of traditional cardiovascular risk factors. And then in animal models, if you take an animal model that's prone to developing atherosclerosis and you introduce these CHIP mutations into marrow, you can accelerate the burden of atherosclerosis. So what's happening here is these mutations occur in stem cells in marrow and become lineage restricted to myeloid populations, so like monocytes and neutrophils. And a monocyte that has a CHIP mutation tends to be more pro-inflammatory. And so these mechanisms in the animal models are mediated by inflammatory cytokine production with things like IL-6 and IL-1. So on that background, it's this concept that somatic mutations can occur in bone marrow and produce inflammatory disease states that then cause cardiovascular disease. got us interested in thinking about the concept of somatic mutations in rheumatologic diseases. And I'm going to tell you a little bit briefly about the discovery of this brand new disease, the VEXAS syndrome. I suspect many of you have probably heard of this disease or even seen a patient with this disease or know about this disease. If you don't know about it, I'll talk to you a little bit about how we discovered it. If you do know about it, I'm going to show you some new data, some of which is unpublished. So this is a brand new disease that was first reported on 3 years ago, and it was discovered by a very large group of investigators at the NIH. And here I'm showing you Building 10, which is the largest research hospital in the world. And this is where we saw all of the original patients with this syndrome. And this is the first VEXAS case that I ever saw. And I actually saw this about a month or two after I'd first come to the NIH, almost 10 years ago now. So this was a man in his 50s who was healthy. And then he started to develop very strange constellation of inflammatory symptoms defined by fevers, orchitis, painful skin nodules, these episodes of periorbital face swelling, which I'll show you in a minute. He'd had 2 deep vein thromboses, and he had these attacks of painful swollen ear sparing the cartilage that sounded like ear chondritis to us. His local doctors in Montana had tried very hard to get his inflammation under control and just were not able to do it with a number of different conventional DMARDs. And eventually they had to put him on cyclophosphamide, which was only temporizing at best. And because of this, they referred him into the undiagnosed disease program at the NIH. This is a program where patients who have unclassifiable things can come for comprehensive evaluation. And when I just joined the NIH, they had pitched me to come be a consultant for the undiagnosed disease program. And they said, we see very weird vascular cases. You'll love it. And I said, great, I'm in. And this was, I think, maybe the first or second case that I saw for them. When we saw this patient, he said, I'm on 25 milligrams of prednisone. I feel great. If you drop my prednisone by 2.5 milligrams, I will flare within a day. And we were in the hospital at the NIH, and we said, great, let's do that experiment. And so we did. We dropped his steroids just slightly. And lo and behold, he started to flare right before our eyes. We saw that periorbital swelling that he was telling us about, which is this picture. We watched a C-reactive protein at admission. It was around 30 mg per liter. It went to over 300 in about 3 or 4 days. And those skin nodules started to appear again on his arms and legs. And we biopsied them, and it showed medium vessel vasculitis in skin. And so that led us to kind of have this working diagnosis that he had polyarteritis nodosa, a medium vessel vasculitis of skin with the testicle inflammation. But there was a lot of other symptoms that we didn't quite understand or didn't fit. And we helped his local doctors manage his condition. We started trying biologics. He had a very nasty skin reaction to anakinra and almost required a skin graft. He had a vasculitic response at the injection site. And he started to develop progressive bone marrow failure. First a macrocytosis, then a macrocytic anemia, then thrombocytopenia. And he had ongoing inflammation. We had to use higher and higher doses of prednisone. He was getting multiple infections. Finally, in 2017, we convinced our hematology colleagues to bone marrow biopsy him because we were worried that he had a myelodysplastic syndrome given the macrocytic anemia. And at this point, he was blood transfusion dependent. But his marrow was non-diagnostic. It showed hypercellular marrow with myeloid predominance, and he had negative cytogenetic genomic studies for MDS. And we just didn't know what he had. He had this weird combination of bad, difficult to treat inflammation with vasculitis and progressive bone marrow failure. And we weren't sure which one was driving which. So we soldiered on. He got worse, started to develop pulmonary infiltrates that only responded to high doses of intravenous glucocorticoids. He developed a disseminated Mycobacteria coloni infection. He now needed platelet transfusions. And unfortunately, in early 2020, he died from multisystemic organ failure complications related to his just general disease. And, I carried this case in my head for a while because I just hadn't seen this pattern of weird bone marrow failure and such difficult to treat vasculitis with such exquisite like glucocorticoid sensitivity. But in 2016, the undiagnosed disease program brought another patient in who was kind of similar, a little bit different, but had that same quality to them. And then a month later in 2016, I saw one of these patients in Dan Kastner's fever team clinic. And at that point, we said, there's 3 of these, they're men, they're middle-aged, let's sequence them and see if they have some common novel genetic mutation. And we did that and we found nothing. We're kind of stuck. And then in the summer of 2019, a clinical fellow named David Beck, who was doing a postdoctoral fellowship in Dan Kastner's lab, called me on the phone and he said, I found this weird mutation in 3 patients. And I knew immediately who he was talking about. And I asked him, okay, how'd you do this? And this is what he told me, that he took a totally different approach to discovering diseases. Normally, when we discover diseases, we look for familial aggregation. So more than one family member has it, and then we segregate those family members and sequence affected and unaffected. Or we look for diseases that begin really, really early in life, thinking that, they're likely to be genetic. But what David did is he took advantage of the fact that at the NIH, we're sequencing everybody. And so the Undiagnosed Disease Program does whole exome sequencing on people, and Dan Kastner's fever team does exome sequencing. And we accumulate these genetic databases. And in this case, we had access to data from 2,560 individuals. Most of the time, we sequence these patients and we don't have a genetic diagnosis, and the database just grows and grows. And so we were interested in the ubiquitin pathway because a number of autoinflammatory diseases have been discovered due to genetic perturbations in this pathway. And if you're a disease discoverer, this is a great pathway to keep in mind because a lot of diseases keep coming out of ubiquitination. But because of that, we restricted this search to 841 genes in these 2,560 individuals. And David applied a filter scheme trying to identify completely novel mutations not described in any healthy human database, as well as mutations that are likely to be pathogenic, things that are intolerant to haploinsufficiency. And from this exercise, out pops 3 men who have missense mutations in codon 41 of a gene called UBA1. Now, he did this without ever looking at the clinical charts, purely agnostic to phenotype. And then when he looked in it, these are these 3 patients, the first one I just told you about, and he called me up and said, what did you see clinically in these people? And we began this partnership that ultimately culminated in the discovery of this disease, the VEXAS syndrome. The first thing that we were puzzled by is that these patients had unusual sequencing data. And these are chromatograms from the first 3 patients. So this is codon 41 of the gene UBA1, and each peak is a single nucleotide. And UBA1 is an X-linked gene, and these are men. So they should have a single peak at each loci. But you'll see with the black arrows, they have a double peak. Instead of 1 read, they have 2. So after excluding things like abnormal karyotyping, we started wondering if this was a somatic mutation. So is it possible that some of the cells in blood are mutant and others are normal, and that's why we see 2 reads? To first prove that, we did skin biopsies of these patients, and we sequenced skin fibroblasts. And we thought, if this is a mutation that's only in the blood, we won't see, everything will look normal in skin. And that's what we saw. You can see their chromatograms, single peaks, everything looks nice. Those mutations aren't there. So at that point, we knew we were dealing with hematologic mosaicism. So some of the cells having a mutation, some don't. And we knew that this was likely a somatic mutation, that it occurred sometime later in life. And we were collaborating with Neil Young's group, who is a group of hematologists that are well-versed in somatic mutations. And we were getting bone marrow biopsies on these patients because their marrow was failing. So we started to sequence purified populations of early hematologic precursor cells, as well as mature blood cells in circulation. And so here's an example for one patient. This is a chromatogram again, UBA1, codon 41. Here's that double peak. The red is the normal read and the blue is the mutation. And if you look at the level of the stem cells, those magical self-renewing cells that are there in your marrow for your entire life, about 30,000 of them or so, you can see an equal blue and red peak. So in this patient, a large proportion of their stem cells have this mutation and another proportion doesn't. And when you chase this through myeloid lineages into mature circulating neutrophils and monocytes, it's almost all blue peak, almost all mutation, very little normal. In contrast, if you go through the lymphoid lineages into mature T cells and B cells, it's nice and normal, 1 peak, all red, there's no mutation. So what this means is that there's a mutation that's starting in the stem cells and clonally expanding through the myeloid population, and somehow there's negative selection, and so any mature lymphocyte that makes it through the process is one that doesn't have the mutation. And we can quantify the size of the clone, the burden of the inflammation, by a metric called the variant allele fraction. So this is an important metric to understand because I'm going to reference this a few times in the talk. Essentially, this is just the number of reads that are mutant versus the total number of reads you get at a position. And so you can see here skin fibroblast, absolutely no mutation. T cells and B cells, no mutation. But if you look in some of these myeloid lineages, you know, in some patients, almost 100% of their neutrophils carry this mutation. We started looking at their bone marrow, and these are bone marrow aspirates from the first 3 patients. And you'll notice immediately that there are these little white dots in the cytoplasm of the erythroid and myeloid precursor cells. So these vacuoles. This is a very sensitive finding in VEXA syndrome, although not every patient has it. And it's quite specific, although there are things like nutritional deficiencies, copper deficiencies, where you can see this. But it's a real clue towards this disease. We named the disease VEXAS, which is an acronym. The V stands for these bone marrow vacuoles. E1 enzyme is the protein encoded for by UBA1. It's X-linked, as I mentioned. It produces autoinflammation with the mutational burden restricted to myeloid populations. And for the biggest point of this talk is it's somatic. So this is not a mutation that these patients inherit from their family members, nor do they pass it along to their kids. It's not gonadal. This is a mutation that's only in their blood, and it had to occur sometime much later in life. And you can see some of the salient features clinically: lung inflammation, skin inflammation, cartilage inflammation, and marrow pathology. And we first reported on this New Year's Eve 2020 in the New England Journal. We had 25 patients for the first report, and you'll see it's a disease of older men. So almost exclusive to the 5th decade of life or later, and 100% of the first 25 were men because it's an X-linked acquired mutation that function. It's like an X-linked recessive disease. Although now we've seen it in women, including women with monosomy of the X, as well as karyotypically normal women. And I think this story will continue to evolve. What got us really excited as clinicians is that these patients had a lot of different clinical diagnoses before we gave them the genetic diagnosis of VEXA syndrome. And what we saw originally was a lot of them were diagnosed with relapsing polychondritis because of the ear inflammation. Many of them had biopsy-proven Sweet syndrome. They had myelodysplastic syndrome. They had different forms of vasculitis. And these were patients that met diagnostic or classification criteria for these conditions. Often the same patient would meet criteria for more than one disease. The dermatologists are really I think the first line of defense in VEXAS because it often starts in the skin. And there's a number of different skin manifestations that I'm showing you here: the ear and nose chondritis, that periorbital inflammation that I showed you in the first case. They get these urticarial-like lesions. They get these neutrophilic dermatosis, those red plaque-like lesions. They can get medium vessel vasculitis with livido, which is why they look like polyhidroitis nodosa. And they can get leukocytoclastic vasculitis. As I mentioned, a lot of them had a clinical diagnosis of relapsing polychondritis, and this is a disease that my group studies at the NIH, and we have a cohort now of over 100 patients. And at the time of first identifying VEXAS, we initially thought it was just going to be a vasculitis, a PAN-like phenotype. And then we noticed that one of those first 3 patients had had a transient episode of ear chondritis. So we had sequencing data on 92 patients with RP from our cohort, and we found that 7 of them had missense mutations that codon 41 of the gene UBA1. So now we know that around 8% of relapsing polychondritis, defined as this clinical entity, is actually this genetic entity of VEXA syndrome. And all of these patients are older men with, in addition to their chondritis, they have hematologic abnormalities. So they're pretty easy to spot once you know what you're looking for. This is the natural history of VEXA syndrome. So it often starts as inflammation, often in the skin. Then you get a macrocytosis and then a macrocytic anemia. And here in this patient, you can see 5 years into disease, they become red blood cell transfusion dependent. And this is their platelet counts progressively becoming thrombocytopenic. And these green arrows are multiple bone marrow biopsies that were done to try to figure out why this patient's becoming cytopenic. And every time they just showed hypercellular marrow, myeloid predominance with those abnormal vacuolated myeloid cells. And eventually at year 6, finally on a bone marrow biopsy, this patient met WHO criteria for a myelodysplastic syndrome. So in many ways, VEXAS is sort of a precursor to a hematologic malignancy. It certainly exists at this kind of crossroads between an inflammatory disease and a hematologic one. We published this paper, as I mentioned, in the last day of 2020, and then we sat back and watched this kind of explode around the world. And you can see exponential increase in number of patient papers related to VEXAS syndrome. And we started to watch different clinicians see different phenotypes within these patients. So VEXAS syndrome looking like acute onset CIDP, VEXAS syndrome looking like HLH. Here's a cohort from France that within a year of our publication, they're publishing on 116 patients with VEXAS syndrome. We started having clues by then that this was actually not going to be exceedingly rare, that it was going to be fairly common, and I'll show you prevalence estimates in a minute. VEXAS syndrome looking like Kikuchi Fujimoto, VEXAS syndrome and lupus, VEXAS syndrome and Behçet's. And I think it's fair to say, like tuberculosis and lupus and renal cell cancer before them, that VEXAS is now a new great mimic in adult internal medicine. A little bit about the mechanism of disease. I'm not going to go too deep here, but you may have noticed that I'm talking about codon 41, and about 70 to 80% of patients with VEXAS have their mutation at codon 41 at this amino acid position. So why is there this mutational hotspot? So to understand that, you have to understand that UBA1 is a gene that encodes for 2 protein isoforms. So UBA1A, which is translation starts at a methionine at codon 1, and it produces this nuclear isoform because there's a nuclear localization sequence right here. And then translation of the shorter cytoplasmic isoform, which we call UBA1B, starts exactly at codon 41, where all of these patients are having these missense mutations. And so what happens is they skip forward to the next methionine, and they translate an even shorter cytoplasmic isoform, which we call UBA1C, which is catalytically impaired. Turns out the story is actually a little more complicated and nuanced than that there is, even with this mutation, some residual translation of UBA1B. And depending on the specific mutation is associated with how much of the actual functional UBA1B that it gets translated. So if you look at a patient with VEXAS syndrome and they have a codon 41 mutation, there's one of 3 scenarios that occurs. Their methionine, either the amino acid substitution happens and it either becomes a leucine, a valine, or a threonine. And the ones with the least residual functional UBA1B are the valines. So you would predict that these are the worst off. And the ones with the most are the leucines. So you would predict that they're the best. And that's what we saw when we looked at survival curves in our cohort. And I say the best and the worst, but overall, I have to emphasize this is a life-threatening severe disease. Our mortality in our cohort is around 25%. Patients usually survive about 10 years or so after symptom onset is the median survival. But if you look at these curves, you see this crazy genotype-phenotype relationship. So the red curves are the valine variants. This is the one that is the worst. And you can see by year 12, each time the curve goes down, a patient has died, unfortunately, and no patient has survived 12 years after onset of symptom with the valine variant. These are the patients that get profound autoinflammation and they get vasculitis. In contrast, the blue is the threonine variant. That's the most common VEXAS variant. These are the older men with relapsing polychondritis. And the best prognosis, at least early on, is the leucines. And these are the patients that get predominantly sweet syndrome, and they get a lot of unusual hematologic abnormalities. And this has been helpful to us because if you have the valine variant, it really lets us know we need to be more aggressive with management early on. On the right is the VEXAS man. As you can see, it's an older man with a lot of different multi-system organ involvement, which is why the disease is this great mimic. And we were flooded with sequencing requests after we published the first paper, and our cohort now is well over 100. And we started to think, this disease is probably going to be fairly common. And so David led this study using genetic data collected with within the Geisinger healthcare system. So in Pennsylvania, if you make contact with the Geisinger healthcare system, either in primary care or in the emergency room or in the hospital, you can agree to allow them to take a genetic sample for exome sequencing. And we got access to that data, roughly around 200,000 exomes. And then we started looking for UBA1 variants, and then we cross-reference those variants with the medical charts to see if they actually had VEXAS syndrome. And what we found is that the prevalence of VEXAS by this cohort is 1 in 14,000. To put that in perspective, that's more common than ALS. It's more common than any myelodysplastic syndrome combined. It's more common than any form of vasculitis except giant cell arteritis. So it's more common than GPA, MPA, EGPA. And when you restrict down to men older than 50, it's 1 in 4,000. That means there's more than 1 million patients in the world with VEXAS syndrome. And what we saw in this database is that there was 100% penetrance. Everybody that had a variant had clinical evidence of VEXAS syndrome with chart review. But more recently, we've now looked in different population databases, and we're getting a slightly different story. So this is work led by Alex Bick's lab in Vanderbilt. And what they did is look at sequencing data in the All of Us program. So for those of you that aren't familiar, this is an NIH-supported program where they're actually going out into the community, shopping malls and things like this, and enrolling patients, and they can participate in a genetic database. So they do whole genome sequencing of patients, and we had access to around 250,000 genomes. And so then we looked again, how many codon 41 variants do we see in this database? And what we found is really interesting. So before we did this study, it looked like 100% penetrance, but there was a lot of bias to that because these were coming from our cohorts of patients that we're defining based on clinical symptoms and coming from Geisinger. And we're seeing these large clones in UBA1 in blood in older men that cause VEXAS every time. But in the All of Us cohort, we found 74 people with missense mutations at codon 41. So this is VEXAS defining mutations. 12 of them were men and 62 of them were women, and 100% of them had the leucine variant. We don't understand why that is. And if you looked at the clone size, these were much smaller clones. And when we looked at the clinical informatics available to us, it didn't look like they had VEXAS. They didn't have hematologic abnormalities. They didn't have diagnostic codes associated with VEXAS. So we're not 100% sure. We're actually in the process of trying to contact these people because we're allowed to do that through All of Us and bring them in and actually study them deeply. But it is possible that maybe some of these patients don't have disease and they're just women that are protected by their second X allele. Maybe we're catching things in the pre-disease state. Or maybe these patients actually have a phenotype. It's just more subtle than the VEXAS one, and we need to actually directly evaluate them. So the goals of medical therapy in VEXAS are to control the inflammation. This is what rheumatologists do best. We don't do it very well in this disease because the only thing that works really well are glucocorticoids. Tocilizumab is our preferred biologic, sort of works okay. JAK inhibitors also can be used. There's a paper that we participated in that showed ruxolitinib had effect. I think you have to be really careful here. These are patients probably that don't have a lot of cytopenias that are early in disease that may respond to this. If you give them later in disease, you can make things worse. IL-1 antagonists likely work, but we avoid anakinra because of those injection site reactions. We've tried some conventional DMARDs, which may help with off-target T-cell activation that we see in the disease. Ideally, we want to get rid of the clone with medical therapy, and there's some promising reports on hypomethylating agents like azacitidine, which are used to treat myelodysplastic syndromes, can actually lower clonal burden of UBA1. So all the stuff that we do as rheumatologists, we're just temporizing inflammation. It's possible that, and we need to find medical therapies that are going to target the clone. And we've gotten much better at preventing complications. These patients get a number of opportunistic infections because the mutation's toxic to lymphocytes. They get lymphopenic, they get PJP, they get disseminated zoster, they get non-tuberculosis mycobacterium, like the case I told you at the beginning. So we've been learning how to deal with those complications. And then there's a high clot signal. This disease, 50% of these patients will have arterial or venous clots. This is a higher clot signal than Behçet's. Because we know the cause of disease, we know it's a clonal disease, we know it's a clonal disease restricted to blood, we can cure them. So we can do allogeneic hematopoietic stem cell transplant. And we've done this on a protocol that we have that's ongoing at the NIH. We've transplanted 5 patients. 1 patient died peri-transplant. That's the problem, is the mortality risk is high. But the other 4 we think we've cured. We've eradicated their clone and they're off of steroids. The problem is they're 65 to 70-year-old men that you're trying to transplant. So finding appropriate transplant candidates is really difficult. And we still need better medical therapy. But it does show you this principle that understanding somatic mutations as causal events, as monogenic drivers of adult onset disease, allows us to then start thinking about, we know what's causing it, we can actually cure these things. Unless you think that VEXAS is a one-off, we actually think that VEXAS is a prototype for a new class of disease. And we've named these hematoinflammatory diseases. We call them this because it emphasizes that a hematologist and a rheumatologist needs to work together to manage these patients. And we define these as hematologic mosaicism, so somatic mutations in blood, systemic inflammation, and a tendency towards progression over time towards myeloproliferative, myelodysplastic, or lymphoproliferative disease. And another perfect example is Erdheim-Chester disease, which is a BRAF mutation restricted to histiocytes, and these patients get bad vasculitis. And here's a patient with bad aortitis who has Erdheim-Chester. So there's something weird going on where somatic mutations in blood like to cause vascular pathology. And we've proposed this schema as a good way to think about this concept, at least in blood, that you can have somatic mutations in stem cells in marrow that become lineage restricted to myeloid populations and produce autoinflammatory disease. This is VEXAS, this is Erdheim-Chester. There's now examples of somatic mutations in the inflammasome causing periodic fever syndromes. But maybe more interesting to general rheumatologists is the concept that you can also get lymphoid lineage restricted mutations, and those may produce autoimmune diseases. So for example, Felty syndrome is associated with acquired mutations in STAT3 in CD8 T cells. The problem with these, the lymphoid mutations, is the abundance of lymphocytes in blood is so low that you have to sequence these patients really deeply to detect these clones, or you have to isolate specific lymphoid lineages and sequence those specifically. For VEXAS, the mutation burden is so high in blood that it was easy to find. It's a large, massive clone on an X-linked gene in men, so we don't even have to deal with their second allele. There's no accident that VEXAS was the first one of these diseases discovered, because if you think about it conceptually, it's probably the easiest one to find. But I think being intentional in this way is going to allow us to actually find these smaller clones hiding out in the lymphoid populations. And I'm going to show you at the end of the talk a brand new form of vasculitis that's through this mechanism. All right, so let's turn up the intensity just a little bit if you're still with me. So right now I've talked about one mutation, a monogenic driver of disease. So you mutate UBA1, you cause disease. But we know it's likely to be more complex than this, and you can acquire many different mutations in the same cell, and that actually will likely affect disease pathogenesis. Similarly, you can probably acquire multiple different clones that interact with each other. So lest you think this is esoteric, let me give you a perfect example of this, and it's in VEXAS syndrome itself. Commercial sequencing is now available for VEXAS, and there's two ways you can do it. You can either sequence the UBA1 gene, or you can add the UBA1 gene into a panel of an NGS panel of genes associated with myeloid leukemias and MDS. So a lot of commercial sequencing companies have just added UBA1 to their MDS panel. And we think this is a great test for VEXAS because you get the UBA1 mutation and you get all these other variants. And this is the typical output that you get from a patient that you sequence on one of these panels. So if we look here, the patient that has UBA1 mutation, it's a 3-enine variant. So they have VEXAS, but they have two other clones detected in blood. And again, the first outset of my talk, I talked to you about clonal hematopoiesis of indeterminate potential, and the main genes of that are DNMT3A and TET2. So here they are popping up again in this same patient. And if we look at the variant allele fraction, size of the clone, the UBA1 is 71% of blood, and these other two are about 30%. So what is going on here? So we just published a paper in Blood looking at clonal hematopoiesis in VEXAS syndrome. And we found that about 60% of our patients with VEXAS will have secondary clonal hematopoiesis mutations in addition to their UBA1 mutation. And often this occurs in one of two patterns. So first, you can have a stem cell and bone marrow that has this typical clonal hematopoiesis mutation, and then inside that cell, they acquire UBA1, and then the UBA1 mutation expands the whole process. This often happens in DNMT3A clones, where you acquire the UBA1 and it expands. And that's why, like the patient I just showed you, the variant allele fraction for the DNMT3A is above 30%. Normally, it would be 5% in typical CH clones. So, but the UBA1 mutation has expanded it. And this is the other way it can happen. The UBA1 clone comes first, and then they acquire a secondary mutation within that. This is often TET2. And why does this matter? Well, it matters because patients who have UBA1 mutations with VEXAS plus either a DNMT3A or a TET2 clone are at increased risk for death. And we think that this actually may give us some functional inroads into how to treat the disease. Hypomethylating agents actually are targeting potentially DNMT3A and TET2, which are genes related to methylation. So it's possible that the patients with VEXA syndrome that respond favorably to meds like azacitidine are the ones that have these passenger mutations that render the UBA1 clone susceptible, but we're still kind of testing that and seeing if that's true. And let me step away from VEXAS and show you why this stuff is going to be important with a totally different example. So this was a case report from Europe in the New England Journal last year. It's an interesting case. So it is a person in their late 20s who developed an LRC4 mediated autoinflammatory disease, so a periodic fever syndrome. And when this patient was in their late 20s, they developed urticaria, pleuropericarditis, and a neutrophilic dermatosis in skin. But if you look at the backstory of this patient, when they were a child, they developed a Ewing sarcoma and were given a lot of chemotherapy. So this patient was in the medical system and they were getting samples over time. And so what they were able to do is go back and look at mutational burden in those samples. And what they found is that when this patient was sometime in their mid-20s, probably as a result of the chemotherapy, they developed early on a typical clonal hematopoiesis mutation in TET2. And within the same TET2 cell, they acquired an NLRC4 mutation. The NLRC4 mutation is toxic, but the TET2 mutation in the same cell gave it that survival advantage that it needed to expand and grow. And you can see both of the clones carrying both TET2 and NLRC4 grew and grew and grew and finally hit a certain size. And then in the yellow, this is when the patient started to develop these symptoms. So it's quite possible that these typical CH mutations are, vectors in which pathogenic mutations can hitch a ride and cause disease. Okay, how much time do we have? All right, I'm going to take us down one last little road, and then we'll wrap things up. One way to think about like typical CH, clonal hematopoiesis mutations, is that they're markers of inflammation. And what is inflammation? It means that as we get older, our immune cell populations have a tendency to become more pro-inflammatory. So these are ABCs and B cells and Temra cells and T cells. But I think in myeloid cells, this is clonal hematopoiesis. So as you're acquiring these mutations, with age, these myeloid cells are becoming more inflammatory. And so we wanted to know, well, CHIP causes inflammatory atherosclerosis. What does it do for normal? What's the prevalence of CHIP in systemic vasculitis? And here you can see our group uses PET scans a lot to actually measure and quantify inflammation in large vessel vasculitides. This is a patient with GCA who's got just profound inflammation throughout their large arteries that we can pick up by a PET scan. And so we were thinking about this and we said, okay, clonal hematopoiesis increases as you get older. What if you look in an inflammatory environment? Does that override the age thing? Meaning that if you're young, but you have bad inflammation, we'll see clonal hematopoiesis. Does it follow the age curve? How does it work? So to do this study, we took patients with Takayasu's arteritis, a disease of the young, ANCA-associated vasculitis, a disease of middle age, and giant cell arteritis, a disease of the elderly. And we sequenced their blood looking for CHIP. And what we found is that both age and inflammation matter. So the prevalence of CHIP in Takayasu's arteritis is 13%. In ANCA-associated vasculitis, middle age is 32%. In our older population of GCA, it's 60%. So, almost every patient with giant cell arteritis already has one of these CH clones. We sequence them at a very high depth. Often CH is called at a variant allele fraction of 2% or higher because that's what you can call from exome data. This was targeted error-corrected sequencing, so we were able to look even down to very, very small clones, and we're kind of glad we did because most of what we saw was actually small clones. We then started to try to think, does this have any functional consequence in these patients? So here you see the Takayasu's patients, almost all DNMT3A, small clones. AAV, it's DNMT3A and TET2, so the usual suspects. And you see a few patients that have a bit larger clones. And then GCA, again, it's almost all DNMT3A and TET2, and some of these patients have massive clones. And it's interesting to think maybe these are passenger mutations. Maybe if we sequenced these cells, we would find driver mutations in GCA. I don't think DNMT3A and TET2 are causal for any of these vasculitis. It's probably they're probably mutations that are accelerated by both aging and by inflammation, but they may play a role in the disease. If you look at the hematologic parameters, the patients that have bigger clones have what you would expect to see. These mutations skew them towards myeloid development. So there are higher neutrophil counts relative to lymphocyte counts. And in the GCA patients, we were able to actually see an important clinical association. We didn't see CH associated with anything related to disease severity, response to treatment, anything like that. But we did see an association with relapse. So patients with GCA who have large CH clones were way more likely to relapse in a gene dose-dependent relationship. We don't understand if the CH clones help propagate and drive relapse, or if just having a lot of relapse creates more inflammation and you select more clones. So it's the chicken and the egg thing. We're not quite sure at this point. And then finally, in the last few minutes, I promised you we have a brand new form of vasculitis. This is it. It's still early days, but it's a disease that's causing medium vessel aneurysms, a very weird form of vasculitis, and it's due to a T cell clone. And this is single cell RNA-seq data. And this population of cells here at cluster 9 is a Th2 clone, and it's monoclonal. When we do VDJ sequencing, it's monoclonal. And we're looking to try to find what the driver mutation is currently in the clone. So VEXAS is proof that somatic mutations in myeloid cells cause systemic vasculitis, and this disease will be proof that somatic mutations in lymphoid populations can also cause vasculitis. All right, so I hope I've convinced you somatic mutations occur in healthy tissue and in disease. VEXAS syndrome is a prototypical new disease defined by somatic mutations in blood in UBA1, that myeloid and lymphoid restricted mutations will be important in rheumatology, and that interactions between acquired mutations within cells and between clonal populations of cells will likely play critical roles in autoinflammation and autoimmune diseases. And with that, thank some of the people in our program here and some of the labs we collaborate, and I'm happy to take questions.
All right. Thank you very, very much for a great talk. I'm particularly excited about it because your findings get fairly close to some of the things that we are very interested in my lab. So I'm going to open the questioning by asking you one question on my mind, which is in these cases of point mutations, do you think neoantigens could be made and presented, and you think that could play a role in how the symptoms and the disease develop?
Yeah, certainly. In tissue, somatic mutations could create neoantigens, and in blood, somatic mutations are the one of the primary ways where we modify autoantibody production. So I think it works at the antibody level and the antigen level. One of my favorite studies actually came out a few years ago in Cell, and what it showed is that in Sjogren's syndrome patients, B cells that make benign rheumatoid factor can acquire lymphoma driver gene mutations, and then they start to make pathogenic rheumatoid factor, which is insoluble, which causes cryoglobulinemic vasculitis in those patients. And that's one step on the train towards developing non-Hodgkin's lymphomas. So yeah, I think definitely neoantigens, definitely autoantibody formation and pathogenicity are going to be linked to this process.
Yeah, okay, thanks very much. So we have a number of questions in the Q&A box. I don't know, Dr. Grayson, if you can see them or if I should read them for you.
I see them. So RALD is RAS-associated autoimmune leukoproliferative disorder. So it's a disease of pediatrics. Don't know much beyond that. Let's see. Grant Hughes, increased UBA1 mutations in women compared to men could reflect enlarged X chromosome complement. Does UBA1 accept, and could this be protective against hypo? So UBA1 does not escape, UBA1 does escape X inactivation. So it could be, they could definitely be protective. But why these mutations are occurring in general at these low clone sizes, and why, if this is fully restricted to the leucine variant, is unclear, other than the fact that the leucine variant is the least pathogenic. So maybe the one that's more likely to occur in a non-disease way. In Erdheim-Chester disease, inhibitors of MAP kinases are very helpful. Is there an analogous inhibitor being developed for VEXAS? So the thing that's really cool about Erdheim-Chester disease and these histiocytoses they're caused by a number of different mutations, and there's actually targeted therapy for those specific mutations. This is the blueprint. If you look and see what's happened in Erdheim-Chester in the last 10 years, they're actually sequencing patients. Depending on the mutation, they may have specific pathway-directed therapies. That's what we want for UBA1. We're not there yet, but obviously this would be a great interest for us. Jane Buckner, do you see any variants in promoters or enhancers? Could this be an additional area to explore somatic mutations? I mean, none that I'm directly familiar with, but certainly I think that's a great thought for sure. Oh man, these just keep coming.
Great talk elicits a lot of questions. That's
Uh,
so Mark Wenner is
yeah, go
is the
ahead. You
next
can
one
ask
there.
it.
Yeah, so he says, great talk, thank you. Do people with mismatch repair defects and related DNA repair defects have higher risk of VEXAS and related somatic cell inflammatory diseases?
We don't know. It will be interesting to look both clinically and scientifically at the things that are causal risk factors for VEXAS, which we're not sure. And a lot of what's happening in the somatic mutation world is having diseases defined by somatic mutations and then doing GWAS studies on those to see if there are germline variants that are associated risk to develop a somatic mutation. And there's definitely precedent of that happening in other diseases. But we don't know. If you think about clonal dynamics of VEXAS, we don't know when these mutations first occur. Do they occur when you're a young child and then slowly expand? Do they occur way late in life and quickly expand? And so maybe you get them when you're 52 and then you have disease when you're 53. We're not sure at all. Nor, I mean, I think the transplant may help us if we transplant them, and these, unfortunately, if these come back, then we'll be able to look at clonal dynamics a little bit, but hopefully the transplant will be curative over a long period of time.
So the next question is from Gordon Starkebaum. What is the difference between mutations causing cancer versus mutations that cause inflammation?
It's a great question, and there's a lot of examples of very interesting genes that do both, and those should be high priorities to look at. My favorite of those is TNFIP3. So that is the A20 gene, so that causes HA20. So mutations at TNFIP3 are associated with B-cell lymphomas. They are associated with this monogenic autoinflammatory disease, HA20. And when I mentioned those B cells in Sjogren's that transform to becoming malignant, often one of the driver mutations is TNFIP3. So there are a lot of genes that I think that are critical to cancer biology and to inflammation, and these are perfect genes to think about this. It could be that where you have an acquired mutation within the gene could skew you more towards a cancer phenotype or to an inflammation phenotype. And often we see both, I think if you think about this conceptually, our diseases that evolve into cancers are so ripe to study in the paradigm of somatic mutations. So inflammatory bowel disease, you're acquiring somatic mutations in tissue and driving you towards cancer. So I think there's going to be examples of the same genes causing both, maybe different locations of the genes, mutations skew one way or the other. Maybe the different cell-specific effects of the same gene mutation will be different. I think it's going to be really complex.
So a question from Rayan Najjar. When discovering a new somatic mutation, how to know if it is causative?
It's quite difficult because when you're sequencing tissue, as I showed you in the first slide, there's mutations everywhere. And it's also difficult if you have low clones, then it's hard to differentiate sequencing error from a true mutation. It's just like everything. I think having a clear association with a clinical phenotype is the easiest way through this. I mean, it was we did zebrafish models for VEXAS and show that UBA1 produces myeloid-driven inflammation, but that's not sufficient evidence probably to be causal. But having, now 2,000 plus patients in the world, all with these same variants, all with the same disease presentation, I think is strong evidence. It's going to be much harder for more complex, non-monogenic things.
So a question from Keith Elkon. Why do different mutations of UBA cause different clinical expression?
Because different amino acids have different translational capacity. So methionine is the best translator amino acid, whereas leucine, you can still translate off of a leucine, but it's not as efficient, and a valine would be less efficient. So I think it's directly related to the amino acid and its efficiency towards initiating translation at these start sites.
Mm-hmm. So Mark Wenner asks, would appreciate your thoughts about clinical labs needs and screening, given need to get high depth of coverage and deeper sequences. Your recommendations, should rheumatologists be able to more routinely order genetic tests?
Okay, so if you think you have a patient with VEXAS syndrome, it's pretty easy. If they've got inflammation in their ears and they're older man, they've got VEXAS. If they have a macrocytosis and high MCV on top of that, they definitely have VEXAS. If you have a patient with bad recurrent skin inflammation and a macrocytosis, they got VEXAS. If you have a patient with bad lung disease and cytopenia and elevated MCV, they probably have VEXAS. So you don't need to, once you start to recognize the pattern, and really realizing that MCV is a critical thing, because a lot of patients have MCV, maybe not in the very, very early stages, but pretty quickly. Then that's your clinical intuition. Because this mutation is massive, you can sequence blood. You only need 3 mLs of blood. You'll pick up this mutation with ease. You could also sequence marrow if you wanted. And right now, these panels, like some of the NGS, the next generation sequencing panels, are covered by insurance if your patient has cytopenia. So there's one by Genome Testing Corporation, or Cooperative, sorry, and they have a UBA1 test on their panel. If your patient has any anemia, you can send it off as a lab, and it comes back within a week or two. So it's really getting easy to actually do this. And I think as rheumatologists, we should routinely order this test and have a low index of suspicion to test for VEXAS in our patients. How this will work down the road remains to be seen, but this is the goal. I mean, if you look at hematology, benign hematology, they're really masters of incorporating molecular diagnostics into their clinical practice. We need to be the same as rheumatologists. I think we've become too reliant on the dark arts of rheumatology. We're so good at making decisions in the face of considerable uncertainties, and we're so good with trusting our clinical instincts that maybe we haven't done enough about molecular characterization of diseases and making our lives ultimately easier when we have these kinds of tests. So this is it's incumbent on us as rheumatologists to understand the somatic mutation paradigm, to look and see what hematology and oncology are doing. When we first discovered VEXAS and we put this out through American College of Rheumatology, it didn't land the way we thought. And it took, I think, rheumatologists about a year or two to get their heads around this concept. When we presented it at hematology, they immediately were like, oh yeah, this is somatic mutation, whatever. No big deal. We see these all the time.
So we have one more question from Mark Wenner. Any NIH experience with calcineurin inhibitors for VEXAS? I have a patient with great response to tacrolimus plus anakinra, now off steroids long term.
We've tried them with variable success. So if you think about the disease, how would you treat it? Well, you want to treat myeloid-driven inflammation. That's why our first line is usually trying to target IL-6, trying to target IL-1. Targeting TNF is disappointing, actually. So why would you target therapies that are directed more towards adaptive immune system and T cells and things like this? And why would those help? The reason is because these dying myeloid cells activate T cells in a non-autonomous way. So when we have partial response to tocilizumab, we often combine with methotrexate or something like this, because I think we're also affecting the adaptive response to this myeloid-driven inflammation. The thing that you have to understand about VEXAS in my mind is that we need to think about it very differently than we typically think about treatment in rheumatology. Often in rheumatology, we have these relapsing, remitting diseases, and we try to find the right drug that works. And once we find it, we are so happy. This is totally different. This is a progressive clonal process that's getting worse and worse. So where you start treatment is likely just as important as when you start treatment. So I can tell you of thousands of patients that have failed, all sorts of things, but it may be because we got to them too late. And with your patient here, what I would wonder is, how quickly did you initiate therapy when they were in the context of their disease? That may be hard to tell, but what was their variant allele fraction? Was their clonal burden smaller than 80%? How long had they had symptoms, and these kinds of clues I think are going to become important. So when we design trials for this disease, clinical trials, inclusion criteria and the patients that we're treating and when in the disease are going to be really, really important.
Okay, I think we are out of questions, and I'd like to thank you one more time for a really fascinating talk, and we will, hopefully get a chance to talk about it, you and I, a little bit later on. So thanks very much.
Yeah, thank you for having me.
Bye-bye.